I think we have 10 participants, and thank you for the opportunity, Dr. Nitin. And today, I think it's a very interesting topic. I think it's a common entity that we see now and then, but we still have few lacunae on to what to do we exactly do and what are the guidelines. And we'll just start from the basics, and we'll also look at some aspects wherein we usually have confusions onto your clinical practice. So, see, the references of febrile seizures and the guidelines are very complicated, and there's no one organization which actually gives you the exact things to be done in febrile seizures, because febrile seizures is a very dynamic situation. You need to individualize each patient, but you still have some broad guidelines onto what needs to be done. So here I have put my references. So it is important to know, I mean, whenever you do something and you need to quote a very valid reference. So ongoing studies on febrile seizures, I mean, there are not many going on, but there's a lot of research which has been done by ILA also, International League Against Epilepsy, and uh, and even American Academy of Pediatrics and American Academy of Neurology also has come up with a lot of information onto what needs to be done in a typical case of a febrile seizure and an atypical case. And recently in 2021, so we also have on the top left, if you see my pointer, so this is AOCN. AOCN is Association of Child Neurology. This is a body which is formed in India, which is uh, by all the pediatric neurologists of India. So we have a consensus statements also given by the experts. So let's talk into the definitions of febrile seizure. I think the definition itself is a controversy. I mean, a lot of we commonly know that the definition of febrile seizures, is typically from 6 months to 60 months or 6 months to 5 years. But if you see, International League Against Epilepsy still says it the definition to be 1 month to 60 months. So, I mean, this is still confusing, but we have other definitions also, which is being updated now. So, the initial proposed paper of ILA said that it was 1 to 16 months. And now the latest statements also say that they agree with the other bodies. So, the most agreed definition is 6 months to 60 months. But if you see National Institutes of Health and the European bodies still sort of think 3 to 60 months as their definition, and American Academy of Neurology also goes along with American Academy of Pediatrics and ILA. So I think most of them, I think we can take a global consensus of 6 months to 60 months should be the definition. And see, regarding this AOCN guidelines, so AOCN is, as I said, Association of Child Neurology. So there has been a study which says it's a Delphi method. So Delphi method is basically a type of study wherein different forms of questionnaires are sent to the physicians, especially the experts in that particular subject, and they are asked about the opinions. So it's like it's not a very good level of evidence, but for conditions which are like having a lot of controversies currently, I mean, Delphi method works pretty well because it just needs to be uh, a message sent all over to different pediatric neurologists and expert opinions. It's like a combined expert opinions of experienced pediatric neurologists. So the guidelines of AOC and febrile seizure guidelines are made like that. So we'll also talk about different type of definitions we currently see in our daily practice. Febrile seizure is any seizure accompanied by fever. We all know that. But the key point here is you should not have a central nervous system infection or a metabolic disorder. So it should not be an acute symptomatic seizure. I mean, for example, if the child has meningitis and the child through a seizure, that won't be a febrile seizure. Or if the child has a dehydration and there's a hyponatremia, and then you have a febrile seizure or a seizure, it won't be a febrile seizure. So it's a seizure accompanied by fever without central nervous system infection or a metabolic dyselectrolytemia or any other sort of infection or trauma which is treatable. So acute symptomatic causes should be ruled out, and CNS infection should be ruled out, and then only you can call it a febrile seizure. If it is typically between 6 months and 5 years, some guidelines also say 6 years. So it's just not like exactly one day after 5 years is not going to be not febrile seizure. It's around 5 to 6 years. So simple febrile, I think you need to know these basics very clearly because we see febrile seizures very often. So simple febrile seizures are synonymous with typical febrile seizures. So you have three criteria. Simple febrile seizure should be a generalized seizure, and the seizure should be lasting less than 5 minutes, and that seizure should not recur within 24 hours. If you see, the definition still says 15 minutes. See, the reason behind this, when the definition for status epilepticus has changed, that itself is an implied statement that a febrile status also is for 5 minutes. But they have not changed it in the literature. But it doesn't necessarily mean that if you see the entire paper of ILA, though the definition stays 15 minutes, but if you see a detailed description, the operational definition is still 5 minutes. So, like the status epilepticus, febrile status epilepticus, also the cutoff is 5 minutes. So, simple febrile seizures should be generalized, should be less than 5 minutes, and should not recur within 24 hours. So, if you exactly break this rule, that is going to be a complex febrile seizure. So, complex febrile seizure can be of three types. The complex febrile seizure or atypical febrile seizure can be a focal onset or prolonged more than 5 minutes or multiple episodes or more than one episode within a 24-hour period. So that is atypical febrile seizure. So here the statement still says 30 minutes, but the operational definition for febrile seizures is 5 minutes. Okay. We'll also discuss about febrile seizure plus and Jeff's plus. This is extremely important. I mean, it is not uncommon in our clinical practice that, sometimes, a child has history of febrile seizures between 1 and 5 years. And all of a sudden, after 5 years, we think that, the febrile seizures are going to stop. And 7 years, 8 years, suddenly they, have a fever triggered seizure. So after 5 years, it is not technically correct to call it a febrile seizure. You can label that a fever triggered seizure or a febrile seizure plus. Okay. So this is a complicated, we have to know what is febrile seizure plus and what is Jeff's plus. So beyond 6 years, this child, if he has a febrile seizure, you can call it febrile seizure or febrile seizure plus. And Jeff's place is a part of a sodium channelopathy. We'll discuss this in our future slides. So the last two entities will have a case entity also. We'll discuss that later. Oh, is my slide moving? Sorry.
You are at genetic epilepsy wala slide.
Yeah,
AOC and yeah. Turn the slide. Next slide, please.
yeah, it's not moving. I think I'll just share again. 1 second. I'm sorry, just give me a minute.
Sure, no problem.
Different pathogenesis, different pathogenesis in this particular slide. uh, After a few years, I mean, when a lot of genetics come up in febrile seizures, so this slide is going to be more important. So if you see febrile seizures is one of the typical example of a multifactorial causative syndrome. So if you see, it's not just one single factor. Why is a particular child more prone for febrile seizure? So it is basically a combination of various factors. For example, it could be a specific viral agent which is triggering with a background of a genetic predisposition. If you see, febrile seizures have a very strong family history, and we'll also get into the family history. What exactly is that? So usually, autosomal dominant inheritance is seen. If you go if you actually dig into the history of febrile seizures, usually one of the parent has a history of febrile seizure. So it is usually a dominant inheritance sodium channelopathy. So we'll also discuss, if you start doing genetics or whole exome sequencing with people with febrile seizure, you will find some sort of sodium channel mutation, but there need to be more studies on that. Not only sodium channel, but also GABA receptor mutation is also seen. And some people have inherent a tendency to have fever because of imbalance between interleukin levels. And if you see infections also, There are few infections which are more prone to have febrile seizures. We'll discuss that in the later slide. So what happens is that there's a background of genetic factors, and you have an infection which is triggering fever and which is actually causing imbalance between the excitatory and inhibitory neurotransmitters. When you have more of excitatory neurotransmitters, that is going to produce a excessive electrical activity, and that causes seizure. So that is a pathogenesis in short. But if you see, there was a controversy. Some There's a school of thought which says that it is not the height of the fever. For example, if you have two kids, one child has 100 fever and the other child has 104 degrees Fahrenheit. So there was a school of thought wherein the height of the fever is not the causative factor, but recent literature again says that height of the factor is actually a key factor. If you take a studies group of few people, 10 children with the 104 degree and another 10 children with around 101 or 102. The group with 104 is likely to have febrile seizure. Okay, but this is again a very small study. It needs to have more evidence to it. All right. So I was talking about what triggers febrile infection. If you see, commonly viral infections are the most commonest in our clinical practice, and even amongst the viral infections, we usually do not find the exact etiology. But if you start doing, viral PCRs or serum PCRs in all the patients with febrile seizures, there was a study which was done, and they found this was a very uh, old study which stated that HHV6 was the most commonly associated virus with febrile seizures, and it is the first virus which is known to be have association with febrile seizures and the studies associated with it. And after that, you also have influenza. Why is it important? Viral infections, you have initial viremia which causes a fever spike. Whenever you have the initial viremia or the primary viremia, you are prone to have very high grade fevers. Despite taking paracetamol, even as the pharmacokinetics of paracetamol come down, you have another spike of fever. So the primary viremia is extremely important, and that's the reason you have more tendency to have febrile seizures with viral infections. Bacterial also, you can also have with UTIs and high grade fevers as such. But in the current context, COVID also has been associated with a lot of febrile seizures. So there was a multicentric study which was conducted. It was a US-based study. So it actually showed the most common neurological complication of COVID-19 associated neurological morbidity is actually febrile seizures. So apart from viral infections like HHV6, influenza, you have other viruses like adenovirus, respiratory syncytial virus, HHV7, even bacterial infections like Shigella dysentery, etc. And after infections, the next commonest thing we see is immunizations. We all know that some vaccines do cause fever because of the antigenicity of that particular vaccine. So that is the same reason why you have febrile seizures. Again, if you see, wholesale pertussis is the main thing which causes. Even you have mumps. So the incidence is very high with live viruses. And in the background of a genetic susceptibility, if you see, we'll discuss about Dravet syndrome and sodium channelopathies. The typical phenotype of Dravet syndrome actually mentions a vaccine-induced febrile seizure. It's very, very important because vaccine-induced febrile seizure always think of an underlying genetic etiology. And this slide is again a very important down the line after 10 years when we have a more solid literature onto what exact gene causes febrile seizure. So they have isolated almost 6 genes which are exclusive for febrile seizure. So they're named as Feb1, 2, 3, 4, 5, and 6 in different chromosomes. There's yet more information to come, but there are other receptors like ChRNA4. So this is a gene which is also associated with autosomal dominant frontal lobe epilepsy. And the second one is GABRA. GABRA is GABR, that is GABA mediated channel, that is also involved in febrile seizures. And as I said, interleukin 1B, interleukin 1RN. If you see the hypothalamic thermostat, that is being regulated by interleukin. So if there's a mutation of that particular gene, then also you'll have more tendency to have febrile seizures. And if you also see, there are few structural abnormalities. For example, if somebody asks you, if a perinatal asphyxia or HI patient is prone to have febrile seizure more than a normal child, what would you answer? The answer is going to be definitely yes. And even if you have an underlying structural abnormality, the risk of febrile seizure is going to be very high. At the same time, if you have a congenital abnormality in the hippocampus, for example, hippocampal malrotation, then also you will have a higher incidence of febrile seizures. And on the contrary, if you have recurrent febrile seizures, there is going to be a condition which is called hippocampal edema. So whenever there is recurrent febrile seizures, you have hippocampal edema, and that eventually can cause medial temporal lobe sclerosis. And again, you will have recurrence of epilepsy because of that. So we'll discuss that in the future slides. So genetics, as of now, we don't have a solid evidence that this particular gene will definitely have, but we have some genes on pipeline, and this along with other factors like epigenetic factors, environmental factors, viral infections, all together will cause a multifactorial kind of picture. So that is the main etiology of febrile seizures. And I was talking about this study. This is a very famous FebStat study. So this was a study which was done in all cases of febrile seizures who had status of prolonged seizures. So this is the, outcome of these studies. They have seen that in that febrile status category, two-thirds, almost like 70% of them actually had focal febrile seizures. And even if you see 76% of people who had febrile status, it was the first episode of febrile seizures. And the most commonly identified virus was HHV6, again, as I said. So this is the febrile study, a febrile status study called FebStat study. They have also found that if there is increased incidence, increased number of recurrences of febrile seizures, then that can cause medial temporal lobe sclerosis and a future risk of unprovoked seizures. Okay, now coming to, it's a common debate when you have clinicians whether a child of around 13 months comes to you with seizures, and during the seizure, because the child is brought to you, the child is in a new environment, the child is in ICU, so he's not very much happy, he's cranky, he's irritable. So then comes the decision whether he's irritable because of an underlying CNS infection, or he's just irritable because of a new environment and a seizure just happened. So here the call or the decision needs to be taken by the clinician. And if the child is active after the seizure or after the post-ictal confusion, if the child is completely active, orally taking well, and his sensorium is perfectly normal, is playful, and his blood culture, CBC, CRP, everything looks normal. If the clinician is convinced that there is no underlying CNS infection, then if the child is more than 1 year, then the call of clinician is important. But American Academy of Pediatrics says that despite the clinical picture of the child, if the child is less than 12 months, especially 6 to 12 months, you have to do an LP, because the signs of meningeal inflammation are not very clear in a child. It looks apparent that the child is normal or irritable just because of seizure, but you may have an underlying CNS infection which can be missed if you don't do an LP. So less than 1 year, be very vigilant, do CSF in all cases, because meningeal signs are not very evident. So this is the guideline which is given by American Academy of Pediatrics and also American Academy of Neurology. So what does AOCN says? AOCN says that AOCN does not talk about whether the child should be less than 6 months, 6 and 12 months. Here the guideline clearly says any child less than 1 year, any child less than 1 year who is the first episode of febrile seizure, if he's not vaccinated for streptococcus pneumonia and Haemophilus influenza. If you see some of them do not know the history of vaccination, or if you don't have a documentation of or an immunization card with them, and you can't take it for sure that they have been vaccinated. Now we have a national schedule which includes pneumococcal vaccine, so we don't have a problem because Haemophilus was included from before as well. So here again, the call is with the clinician. And there's another clause here: the child is more than 1 year, and the child has been given antibiotics by an outside physician. The child had fever, the child received augmentin, and then after 2 days, the child had a seizure. And then if you have an underlying CNS infection that you will not have the clear signs of meningeal inflammation. In that case, also, better do an LP, exclude rather than missing, and also rely on clinical signs. And if you have a doubt that there is a suspected infection, a CNS infection, and you're also suspecting that there is a sign of raised ICT or any focal deficits, then you do a neuroimaging before lumbar puncture, because that would be a safer procedure to provide to avoid complications like herniation, etc. Okay, and then coming to focal, when do you call actually atypical febrile seizures? Atypical febrile seizures, as I said, it can be either focal, it can be either prolonged febrile seizures, or it could be within 24 hours 2 episodes. So it is a common thing that most of us actually miss a focal febrile seizure. So Eiley clearly mentions it's not a focal, it's just not focal febrile seizure, it's focal onset. So always ask parents regarding the onset of the seizure, whether there was a version of eyes, whether there was deviation of eyes towards one side, whether there was head version, there's abnormal tonic posting of the head towards left side or right side needs to be asked. It's extremely important. That is a very subtle sign, because we usually ask, all four limbs moved or not. All four limbs usually move, even in focal onset, but head version and eye version is very important and gives you a focal localization. In that case, it's very important to do a neuroimaging. Focal febrile seizures actually need neuroimaging. So we'll discuss when to do MRI, when to do EEG as well. So here, EEG. So the division of typical febrile seizure and atypical febrile seizure is done to basically know what needs to be done. For example, a simple febrile seizure does not warrant anything. It does not warrant EEG, does not warrant neuroimaging, and it does not warrant even LP if the child is more than 1 year and does not have any CNS manifestations. Okay. But on the other hand, if the child has atypical febrile seizure, I'll give you an example of why EEG and neuroimaging are going to be important. For example, a child has fever and a seizure at 18 months of age, and we think it is no febrile, just a febrile seizure, and we have started clobazam prophylaxis, and you have discharged the child after 48 hours because there was no seizure. And you later on come to know that no child has worsened, and if you do a neuroimaging, that child ended up having herpes encephalitis. So herpes encephalitis will have unilateral affection of temporal lobe that can cause focal seizure. Okay, and that focal seizure has been treated as febrile seizure. So you're going to miss a treatable cause of encephalitis. So whenever you have a focal seizure, always rule out an underlying structural cause. Like for example, even neurocysticercosis can present with a focal febrile seizure. Tuberculoma can present with focal febrile seizure, and herpes encephalitis can present with focal febrile seizure. So in this particular context of focal febrile seizure, neuroimaging is extremely important, and EEG is also extremely important. So EEG sometimes can give you clues of focal epileptiform discharges. For example, periodic discharges or lateralized discharges. So what you see in herpes encephalitis is PLEDs, periodic lateralized epileptiform discharges. That can be, sometimes useful, in diagnosing a focal pathology. Not only focal seizure, but also prolonged febrile status also needs both neuroimaging and an EEG. So simple to remember, in typical febrile seizure or simple febrile seizure, EEG, MRI is not needed. Or atypical febrile seizure, focal seizure and a prolonged seizure, or febrile status or focal febrile seizure, they need both EEG and MRI. But the third type of atypical febrile seizure, wherein within 24 hours, if you have 2 episodes, this is a relatively benign entity among the atypical febrile seizure. You don't usually need an EEG. You have to treat this as a typical febrile seizure. I hope I'm clear with this. And after doing an EEG, for example, see, doing an EEG in a febrile seizure is a very dicey thing, because if you do EEG within first 48 hours of a febrile seizure, you will have very non-specific epileptiform discharges. And seeing those epileptiform discharges, you will, a lot of them tend to start anti-epileptic drugs on a long term or a chronic anti-epileptic therapy, which is usually not warranted. Even if you plan to do an EEG in a focal febrile seizure, it does not necessarily mean that you have to start an anti-epileptic drug. EEG is just to find out what is the probabilityology, and maybe you do an MRI and find out a cause for that. All right. So this is about EEG and neuroimaging and LP. So I hope I'm clear. LP less than 1 year, always do an LP to rule out CNS infection. More than 12 months or 1 year, it depends on the clinician's call. If you have meningeal signs, so look at the whole child in the picture. Examination, history, what is the CBC, CRP, ProCal. Look at everything and make a call if the child is more than 1 year. Less than 1 year, do LP. And if you have focal signs or raised SCD signs, do an MRI and then do an LP. And coming to EEG, EEG and MRI is required in atypical febrile seizures, especially focal febrile seizure and focal and febrile status. So that is a summary of what we have talked about till now. And this, I think everybody knows. How do you manage a case of febrile seizures? Even febrile seizures can be very devastating for the parents. They'll be very anxious and they'll come to you. So the main management is, first thing you do is try to find the cause of fever, because you need to treat that, or else fever is going to come back again and the child can have seizure again. Second thing, controlling the pyrexia. That's extremely important. I think you know better than us. Controlling pyrexia, you can have various medications. Lipid sponging needs to be focused on. And when if the child is brought to you seizing, that means if see, operational definition says that more than 5 minutes is febrile status, and or the child is brought to you seizing, so we assume that the transport at least 5 minutes must have been passed. So if the child is brought to you seizing, then you can take that as febrile status. In febrile status, you might have to start an additional anti-seizure medication. You may need to load the patient with Levipil or phenytoin or valproate. Okay, and then how long do you continue in febrile status? Usually, it's recommended to continue anti-epileptic therapy for 3 months, and then later on decide based on the recurrence. All right, and controlling the seizure at that moment. For example, uh, the child is brought to you, immediate aborting of the seizure can be done with intravenous midazolam or lorazepam or diazepam, as like any other status epilepticus. And coming to before, this was a major talk wherein, previously they used to do oral or rectal diazepam, which is not warranted anymore, or we don't use any other uh, prolonged anti seizure medications like phenobarbital, which is not recommended. And coming to intermittent prophylactic ASM, that this is another debatable topic, but we all give frisium prophylaxis, right? Clobazam for all patients of febrile seizure, the second episode, 1 mg per kg per day for 3 to 5 days. So this actually lacks evidence. There's only low quality evidence that intermittent prophylaxis of clobazam will help in preventing recurrence of a febrile seizure. So there's no strong evidence for that. So a lot of people abroad do not actually give clobazam intermittent prophylaxis. Especially, it clearly mentioned in AOCN that if the parental anxiety is too much, or uh, the I mean that's the main thing. What we do is to decrease the morbidity and the anxiety which you have in the recurrent febrile seizures. That is the main aim. So basically, intermittent clobazam prophylaxis is not gonna technically decrease the future risk of epilepsy or febrile seizures, but there is some evidence, but not a strong evidence of giving clobazam prophylaxis. So that is both by American Academy of Pediatrics as well as AOCN. And how about long-term prophylaxis? That, for example, the child has come to me, as I said, if the child is admitted in PICU for febrile status epilepticus, do not discharge the patient without an anti-epileptic drug. You have to start an anti-seizure medication. And this is the condition wherein you start the medication and then later on decide whether the recurrence is low or not, because febrile status has a very significant morbidity and mortality, and you should not land back again in your PICU. So you can consider a long-term prophylaxis, continuous prophylaxis. Second thing, febrile seizures patient, you have come and, for example, the child has a focal seizure and you have done an MRI which showed a perinatal asphyxia or an underlying structural abnormality, or the child has neurodevelopmental delay or a structural focus, then you have to continue the medication, because this child will have high recurrence of febrile seizures as well as unprovoked seizures. So this child, you can consider continuing prophylaxis, that is continuous prophylaxis on a long term, that is for 1 year or 2 years. And third one is a little gray zone. Frequent atypical febrile seizures you may consider, because this child will have something underlying, like a genetic cause or a structural cause. And the last entity, that is febrile seizures plus and Jeff's plus. So these are basically a type of channelopathies. We'll discuss this in the last. So in these also you can consider giving long-term prophylaxis. And as we know that the commonest medication that we start is levetiracetam, but unfortunately that's not the drug of choice. If you see, valproate is a drug of choice in long-term prophylaxis. But if you see practically, the safety-wise, levetiracetam is going to be more feasible when you compare to valproate, because valproate will need 3 monthly or 6 monthly screening of liver function tests, and you also have side effects like weight gain, etc. And this will also discuss how long do we give. Like if you start medication in these the last two entities, that is febrile seizures plus and Jeff's plus, you may have to consider giving for a long duration. Okay, so this again is not of that importance because this was previously a table for recurrence risk when you explain the parents. So age less than 18 months and the duration of fever less than 1 hour. For example, the child has fever and within less than an hour, the child has a febrile seizure. So that is again an increased risk. First degree relative and fever less than 104. I mean, this is not that important, but in this, the practically what is important is the first degree relative. If you have the family history, there's a higher chance of recurrence. Okay, this is the risk of future epilepsy. For example, if you have an underlying structural malformation presenting with complex febrile seizure like focal febrile seizure, or there's a family history, again underlying neurodevelopmental abnormality like cerebral palsy, HIE. As I said, HIE can have peri-Rolandic hyperintensities on MRI. So that can actually, as a structural focus, it can have increased risk of febrile seizure. I mean, this is also an increased risk for epilepsy, that is, unprovoked seizures also. So that is about the febrile seizures basic. We'll actually, I think, we'll go for the case studies now. I hope my screen is visible.
Yeah, it is visible.
Yeah, 1 second. Meanwhile, if anybody wants to ask any doubt, we can actually discuss. I mean, it's a very common topic. I think anybody from the chat.
All of you can put your doubts in chat box, please.
Okay. Where is the full screen? Yeah. Okay. So this is going to be, I think you can put it in the chat box. I mean, we can make it an interactive as well. We'll do a few case studies as well. All right. So in the chat box, sir, do you want me to answer these now or the end of the quiz? End of the
Put
talk?
it in the form of an answer. You can check the answers at the chat in chat box. Those who participate, we will
Yes.
reply
Yes.
there.
So as somebody asked, there are 3 to 4 episodes in febrile episode within 1 day and more than 1 year, and all investigations normal. Is it? No, it is not going to be typical because if you see 3 or 4 episodes in one particular day itself is a criteria for atypical febrile seizure. And if in within the same half an hour, if the child seizes 3 or 4 times, that can be taken as febrile status. So either ways, this is going to be atypical febrile seizure. And the second question, clobazam will take 9 to 10 days to achieve therapeutic levels. Then how is it going to be given for three? No. So this is the clobazam efficacy of this is the what you're talking about is 9 to 10 days is for the long-term prophylaxis of as an add-on drug. See, clobazam is commonly used as an add-on drug in epilepsy cases like focal epilepsies. So the mechanism is quite different in febrile seizures. In febrile seizures, we only tend to give for 3 to 5 days. The action begins within as early as 12 hours. So it's just going to prevent. So as you said, the efficacy is not going to be very extremely good because the therapeutic levels are not going to be that good, but it's just going to prevent next seizure. I mean, that's the reason the efficacy, I mean, the evidence is also low. All right, we'll take up this case first. Oh, is it moving? Yeah. 3-year-old boy presented with history of one episode of generalized tonic-clonic seizures lasting for 5 minutes. Okay. And there's history of associated fever, cough, and cold. There is history of one similar episode at 2 years of age. Now currently he's 3 years old. And nothing on perinatal history, development history, and family history. And on examination, the child was febrile. The fever was 101.5. Vitals were stable, and he regained complete consciousness within 15 minutes of seizures. And is oriented to time, place, and person. No meningeal signs, and no other focal neurological signs. So, what does it look like? Does it look like typical febrile seizure or atypical febrile seizure? Anybody? We can put your answers in the chat. Yeah, I think we have a lot of answers saying it's typical febrile seizures, right? So hemogram showed the TLC of 9,000. Though it looks typical, it's anyways as a part of workup of your fever profile, you can do your workup. TLC has 9,000 cells, neutrophils of 78, platelet count of 2.2, CRP of 12. There's some mild infection going on there. Okay, serum electrolytes, calcium, ionic calcium, everything was normal. And you can answer EEG needs to be done in this case. I hope you're answering no. How about neuroimaging? Because this is a typical febrile seizure, and I've mentioned clearly that there's no focality. It's a generalized tonic-clonic seizures. There was no focal onset semiology. So I would not do a neuroimaging in this case. Lumbar puncture, the TLC looks okay, and the child is not less than 1 year. The child is 3 years old. He's oriented to time, place, and person. No meningeal signs. I would not do a lumbar puncture. So diagnosis would be a typical febrile seizure, simple febrile seizure. All right. So this is a typical case. Coming to the second case, 4-year-old boy presenting with history of 3 episodes of generalized clonic seizures in the last 24 hours. I think somebody already asked this question. Each lasting for 5 minutes, associated with fever and loose stools. So if you want to put this, I mean, would you call it a typical or atypical? So obviously it is complex or typical, atypical, because there are 3 episodes in one day. And there is history of one similar episode at 2 years of age. Okay. And there's no significant perinatal development or family history. And on examination, the child is again febrile with 1.5, stable vitals, regain consciousness within 15 minutes, and no meningeal signs and no focal deficits. And you can put it on the chat box. Would you call it atypical febrile seizure or typical febrile seizures? Yes, atypical. Rightly said, because there were multiple episodes. Okay, TLC, CRP, electrolytes, serum calcium, ionic calcium, everything is normal. Diagnosis is going to be atypical febrile seizure because there were 3 episodes in one day. EEG needs to be done. How about EEG and LP? Why do you want to do an EEG? We just discussed. Because in atypical, you have two categories here, right? In atypical, you have one type of atypical, as we discussed, there are 3 types of atypicals. One atypical is focal, one atypical is febrile status, and third atypical is more than one episode in 24 hours. In this particular condition, I mean, you would not do an EEG because I'm not getting anything extra. And neuroimaging also, I would not do neuroimaging in this case. So I hope I'm clear here. I'll just discuss this again. In atypical, there are 3 types. First one is a focal febrile seizure. Second one is febrile status. Third is more than one episode in 24 hours. So these are the 3 defining criteria for atypical. In the first 2 criteria, that is focal and status, you have to do EEG and MRI. Whereas in the third category, within 24 hours, if you have 2 episodes or 3 episodes, you don't do EEG or MRI. This is according to the AOCN guidelines. All right. And this is up to you. Intermittent prophylaxis can be started. All right. So let's go to the third case. I mean, it's going to be difficult now. We'll have tough cases now. I hope we'll have answers. 3-year-old girl presented to the emergency seizing with history of GTCS in the last 45 minutes. I mean, she's seizing for a long time. She's brought to you to the emergency seizing. So this is definitely a febrile status, right? I hope you agree with it. And there's history of fever and rash since 2 days. There's no significant perinatal development or family history. On examination, the child has very high fever, 103.5. The child is sedated and intubated in your status. Started on 2 anti-seizure medications and midazolam drip. Okay, this is an indication that we are dealing with probably a refractory status epilepticus. And on examination, there are no meningeal signs, no focal deficits on examination. So I think you must be agreeing with the fact that this is, let's see the chat, needs anti-epileptic, very correct. And I think everybody should agree with it because it's a TLC of this child. Again, serum electrolytes is nothing significant. It's a complex febrile seizure presenting as febrile status. EEG needs to be done, yes. Neuroimaging needs to be done, yes. Lumbar puncture, depending on the clinical strata. I mean, if there are no medical meningeal signs, if there are no focal deficits and no infection signs, I would not do a lumbar puncture in this particular case, but it's up to the clinician judgment. And this particular child will need at least 3 months of anti-seizure medications and then review the case if you might need a long-term prophylaxis. All right. Okay, let's go to the next case. 1-month-old girl was brought with acute clustering of 3 seizures in 2 days. So in the last 48 hours, there are 3 seizures with history of high-grade fever. On the backdrop, this child had normal perinatal history and was thriving well. On examination, the child was sedated post-midazolam, vitals fever of 101, and there was tachycardia, and the child was re-examined after 1 hour, had persistent and inconsolable cry. On examination, there was bulging anterior fontanelle and brisk reflexes, and no apparent meningeal signs. What next? So I need answers for this. What do you think this is? Somebody said EEG and MRI and LP. Absolutely. So this is the example which I was saying. This child will fall into the category of less than 1 year, and this is even more crucial age of 1 month. So any child who comes with this type of presentation and anterior fontanelle is bulging as well, and the brisk reflexes, this is probably CNS infection. You need to rule out a CNS infection, and you have to probably consider imaging LP. So this won't be falling into the category of febrile seizures per se, because the accepted consensus statements is now 6 months to 60 months. So this won't be a febrile seizure. So this will be an acute CNS infection. So you have to do a CSF analysis and probably consider neuroimaging and also EEG. EEG will also give clues in these cases. Like, you're dealing with acute encephalopathy in a neonate. You also do an EEG to look for burst suppression, non-convulsive status epilepticus, and also how is the encephalopathy, how severe is encephalopathy, mild, moderate, or severe. All that grading can be done from EEG. So all three needs to be done in this case. I hope you agree with it. And TLC was very high. It was neutrophilic and CRP was positive. And 3 Tesla MRI was done with contrast, which showed leptomeningeal enhancement and prominent ventricle. So this is suggestive of a CNS infection. And as you suggested, LP was done, CSF had cells, predominantly neutrophils. So diagnosis will be this is an acute CNS infection or a meningitis picture. All right. So this will be a fever triggered seizure or a fever provoked seizure. So this won't be included into the definition of febrile seizure. This is also important for you. All right. Let's go to the fourth case quickly. 8-year-old boy presented to the emergency room again with history of one episode of generalized tonic-clonic seizures lasting for 5 minutes. I think I need inputs here because this child is 8 year old and he was brought to the emergency. So probably of a febrile status. See, exactly, he's exactly at the borderline of 5 minutes. So it could be a status or could not be a status. And there's history of associated fever, cough, and cold. On the backdrop, the child had 2 episodes of typical febrile seizures at 2 years, 2.5 years, and also at 3 years, total three, for which he was not started on any anti-seizure medication. This technically tells you that these were all typical seizures. All right. So that was the clue which I was getting from the history. And no significant perinatal history, development family history, no family history as well. On examination, the child was febrile, but vitals were stable. He regained consciousness within 15 minutes of seizure, and he was totally oriented to time, place, and he was answering all the questions. No meningeal signs on examination, and no focal deficits on examination. So, what would you call this entity, and how would you treat this? I think I'll just check the chat box. Somebody said febrile seizures plus. Absolutely. All right. So let's see. So hemogram was not significant. CRP was mildly elevated. Serum electrolytes were normal. Calcium was normal. EEG needs to be done because EEG, it's not like a hard and fast rule. EEG can be considered in this case because it is not a typical age for febrile seizures. Neuroimaging is, I don't think neuroimaging would be any beneficial in this case. Febrile seizures would have a normal MRI. Diagnosis, as you said, is febrile seizures plus. This is not a rare thing. We usually see this in, a clinical practice. You need to counsel the parents. The recurrence of febrile seizure plus is unpredictable. Sometimes, most of them, 70 to 80% of them, do not have seizure again. And sometimes they can have recurrence as well. Okay. Last case. I mean, this is the last part one. 7-year-old boy was rushed into emergency with history of one episode of GTCS, same picture. There was no associated fever. Okay. On the backdrop, the child had 3 episodes of typical febrile seizures, the same age, the same as the typical previous case, but this time this child does not have fever. However, there's a family history of febrile seizures and unprovoked seizures in the father, along with mild development delay in the cognitive domains, which was caught up. So this is a very interesting entity. On examination, the vitals were stable. He was oriented to time, place, and person. There was no status, no meningeal signs, or no focal deficits. What do you think this is? Jeff's plus. Fires, somebody said fires. Fires would be a refractory. Fires itself has Febrile illness-induced refractory epilepticus, status epilepticus. So this is not refractory epileptic status epilepticus. So I wouldn't call this fires, and there's no associated fever. So this would be Jeff's plus. Jeff's plus, as I said, is an underlying genetic generalized epilepsy with febrile seizures. So it is a form of sodium channelopathy, and usually it has autosomal dominant inheritance. So you will have some sort of family history in the parents. For some reason, males tend to have high penetrance. For example, so whenever you talk about autosomal dominant disease, you have to talk about penetrance. Some of them have a very mild disease. That means they're less penetrant. Sometimes the father has only one seizure, but the child has multiple seizures. That means the father was less penetrant, the child was more penetrant. So when it comes to autosomal dominant disease, there is variable penetrance. So as you said, Jeff's is correct answer. Let's see what is CBC was not contributory electrolytes, acute symptom. This is to emphasize again and again that in any case of seizure, keep doing routine parameters, keep doing electrolytes, keep doing calcium. It's extremely important. They're treatable. EEG can be done in this case. Is indicated. I mean, it depends again because you will have clues. Channelopathies will have particular clues on EEGs. Neuroimaging, I wouldn't do in this case because I'm not expecting something structural. Diagnosis, as you said, is generalized epilepsy with febrile seizures plus. This is Jeff's plus. So this child had SCN1A. This is generalized epilepsy with febrile seizures type 2. As I said, it's a sodium channelopathy. SCN1A is a sodium channelopathy. So this is a spectrum of Jeff's plus. Jeff's plus is one of the examples of a genetic disorder with variable presentation and variable expressivity. Some people have just febrile seizures and then nothing will happen after that. Some people end up having febrile seizures plus, and some people have different forms of seizures like complex phenotypes, myoclonic atonic seizures, focal epilepsy alone, other types of seizures as well, even Dravet, full-fledged Dravet phenotype. We'll also discuss about Dravet phenotype in this context. So there are three types of Jeff's plus. I won't go into the details of it, but you have to remember Jeff's plus is usually sodium channelopathy, rarely GABR, that is Gabra G, but usually sodium channelopathy, autosomal dominant inheritance can present with varied form of presentations like febrile seizures plus, Jeff's plus, Dravet phenotype, any type of complex phenotypes. And lastly, this is the last case. 4-year-old boy was rushed into the emergency with history of one episode of GTCS lasting for 25 minutes. Associated with fever, was loaded with phosphenytoin. Seizures persisted for another 30 minutes, shifted to PICU, and was loaded with other anti-seizure medications and eventually turned to midazolam drip. So from the history, it looks like refractory status epilepticus because he was bought with seizures. On the backdrop, the child had 3 episodes of typical febrile seizures at 2 years, 1 episode of febrile seizure within 12 hours of DPT booster, 1 episode while bathing the child with multiple unprovoked focal seizures, generalized seizures after 3 years of age. So this child seems to have a lot of different types of seizures, but have given you a lot of clues. I think you will be able to answer this. No significant perinatal family history. However, there's developmental slowing noted from 2 to 3 years in the cognitive and language domains, and that his child is managed in PICU, seizures controlled after midazolam trips. So what do you think this is? Dravet, perfect. So I'll tell you some clues of Dravet. Dravet, for your information, Dravet is a female pediatric neurologist. She's still alive, and she worked her entire life for the last 50 years on this particular syndrome to coin this term. So Dravet has a varied phenotype. So it is basically a sodium channelopathy. The SCN1A is the gene which is involved in Dravet. So usually the typical phenotype has a presentation of a cognitive or a developmental slowing somewhere between 1 to 4 years of age. They have fever triggered febrile seizures, and then they tend to have atypical febrile seizures, and then they tend to have unprovoked seizures also. And they have reflex epilepsy. For example, the child is going for hot shower. If you bathe the child with hot or warm water, they tend to have seizures. So basically, these are called reflex seizures. Okay, it's very important. This is sometimes given in the history. Whenever you have a hot water bath, then the child has seizure. And the second clue here is vaccine-induced seizure. Vaccine-induced febrile seizure is common in Dravet, and this child also has developmental slowing. And Dravet can present in any way. It can even present with status epilepticus as well. So as this was a status epilepticus, I did an MRI which came out to be normal. I did infection workup which came out to be normal. Bedside EEG was done because it was a status epilepticus, which showed generalized slowing, which was not specific. But however, I wanted to rule out non-convulsive status epilepticus. On EEG, on day 2, it was multifocal IIDs with intermittent generalization. So this is a very non-specific feature of the genetic channelopathy. And neurology consultation was taken, and phosphoenatoin was stopped. If you see history here, when the child came with seizures lasting for 25 minutes, the the physician in the emergency room has started with phosphoenatoin, and the seizures persisted beyond that. So that is one of the clue. Wherever you give a sodium channel blocker to a child with Dravet syndrome, you will have increased seizure frequency, and you will have, even if you give it to a normal child, he will go into status. So that is also an indirect clue that you're probably dealing with a sodium channelopathy. All right. So I think we'll also go to the last quiz. What are the other sodium channel blockers you would like to avoid in Dravet? Whenever you have a child with Dravet syndrome diagnosis, you have to write it in an OPD sheet. This is a child of Dravet syndrome. All these drugs need to be avoided because this child will go into a remote place, and if the child has a seizure, he'll be taken to a nearby general practice or a PHC, and he'll be loaded with phenytoin again. So apart from phenytoin, what are the other drugs which you need to avoid in Dravet? Carbamazepine, correct, because carbamazepine is a sodium channel blocker. More. So there are 6 drugs. You have to remember the list, and you have to write in caps in all the OPD sheets and even in your IPD sheets specifically to avoid that. First one is phosphoenatoin. Second is phenytoin. Third is carbamazepine. Fourth is oxcarbazepine. Fifth is lacosamide. Sixth, see, these are the main ones. Topiramate and zonisamide also have a slight mechanism of sodium channel blocking, and lamotrigine is also a sodium channel blocker. So I'll repeat 6: phosphoenatoin, phenytoin, carbamazepine, oxcarbazepine, lamotrigine, and lacosamide. These are the 6 drugs you need to avoid in Dravet syndrome because these are sodium channel blockers. Dravet already has a defect in sodium channel. You're going to further block because the seizures will increase again. So this is Dravet syndrome. So this child had HCN1A on whole exome sequencing. All right. So this is about Dravet syndrome. Again, Dravet syndrome incidence is now, it's been mostly diagnosed in India as well. And you have a varied spectrum, as I mentioned. This is the spectrum as SCN1. Can present with, childhood onset epilepsy till febrile seizures plus till typical Dravet phenotype. Also remember the drug of choice in Dravet syndrome is valproate. There are other drugs. Fenfluramine is not available in India. Stilipintrol is not clearly available in India. Clobazam is a very good drug in Dravet. And third line, now cannabidiol is freely available in India. If you have a refractory seizure in the case of Dravet syndrome, you can use cannabidiol. Fourth line drug, topiramate, is a very good drug. Topiramate acts on various mechanisms, not necessarily sodium, so it can be used. Ketogenic diet is also very effective in Dravet syndrome. And as I said, avoid all the sodium channel blockers, especially phenytoin, phosphoenatoin, carbamazepine, oxcarb, lamotrigine, and phenytoin, as I said. Lamotrigine, lacosamide is not mentioned here. Lacosamide also is a sodium channel blocker. I think that is it. So we had 6 cases of all the prototype cases. Any other doubts, you can post it on the chat box. Excuse me. Hello, sir. Dr. Nitin, are you here?
मैं यही हूँ, मेरा सिग्नल बंद हुआ था.
Okay.
All well?
Yes, sir. Yeah. So I'm just waiting. I finished all the cases. I'm waiting for any questions to take up.
I am unable to, because of the signal issue, I am unable to see any questions. There was one question. Can you see the chat box?
Yes, sir. Yes, sir. I have answered all the chat box questions actually. So somebody
Great.
asked, is it always associated with developmental delay? No, Dravet actually has varied phenotype. Most of them have some sort of developmental slowing. I think we still have 30 people online, I think. Okay. Somebody asked role of zinc deficiency in febrile seizures. Actually, there are a lot of studies on micronutrients in febrile seizures. Actually, there are a lot of theses, ongoing studies of zinc and magnesium, but there's no solid or clear-cut evidence that zinc deficiency has a role. And there is also a study of iron deficiency. Iron deficiency, zinc and magnesium have roles, but no solid evidence. Yeah, as I said, iron deficiency again. So there is a lot of expert opinion saying that an iron deficiency is common in India. That is the reason we have very common incidence of febrile seizures, but we don't have good studies to confirm that theory. Yeah, any condition where high dose phenytoin is effective. It's a very good question. So I'll tell you a very interesting topic here. So whenever you have sodium channelopathy, so sodium channelopathy is a genetic origin sodium channelopathy. So they have two types of presentation of sodium channelopathy. So one type of presentation in the first 3 months, which is called gain of function sodium channelopathy. In the first 3 months, for some reason, that channel is working more than normal. All right. So in that first 3 months, for example, if a sodium channelopathy comes in the first 3 months, it's usually gain of function, and they respond very well to sodium channel blockers. So whenever you have a developmental epileptic encephalopathy in the first 3 months or in neonatal onset epilepsy, you with the genetics done, you see a sodium channel mutation. And in the genetic report, they usually give it's a loss of function or a gain of function. In the first 3 months, it is gain of function. In that particular condition, for sodium channel blockers will help. So that is one condition. Can CP children have simple febrile seizures of prolonged? Yes, absolutely. Because here, CP children will have some sort of neurological damage. So you'll have structural lesion in the brain. For example, the most common patterns of CP children, you'll have peri-Rolandic pattern of hyperintensities. You have watershed infarcts, hyperintensities. All these can have structural focus. So these children are prone to have more frequent febrile seizures, prolonged febrile seizures, and also unprovoked seizures as well. Any other questions?
I think with this extensive overview with so many case studies, most of the questions are already being answered. And if at all there are any questions, then please feel free to pass it on to me, and I will share it with Dr. Jayanth, and we are easily approachable. Second thing is I'm very excited that we are going to start a 6-month genetic program. The process of filing the application to get approval from the accreditation bodies is already in place, and Dr. Jain will be head of as a chief mentor. He will be the one